So good afternoon, everyone, and welcome on behalf of the Alzheimer's Society of PEI. My name is Jamie Constable. I'm the CEO here, and I'm joined today by Shelley King. She's a licensed practical nurse who is also our Dementia Care Educator on the island. Welcome to the launch of our Lunchtime Learning Series, which will be a series of ongoing presentations, just brief 30-minute sessions on special topics related to dementia. The sessions are appropriate for healthcare providers, community care providers, as well as family members or persons affected by Alzheimer's and dementia. I'm going to invite you throughout the session, if you do have questions, to please post them into the chat pod. We will spend some time after the session at around 12:30, where we'll just open the floor up for questions and discussion. But we do have a lot of material to cover in the 30 minutes. As well, we are recording the session today so that we can post it on our YouTube channel, and you're welcome to review it at any time. A reminder once again for anybody who's just joining us, please keep your microphone on mute so that we can minimize the amount of background noise that's happening. And lastly, thank you again for joining us. I'm going to turn things over to Shelley, and I hope you enjoy this presentation today. We will put up a brief evaluation on your screen afterwards. It's only a few questions, and we'd appreciate your feedback since this is a new initiative and we want to make sure we're meeting your needs and just help us as we plan for future sessions. So again, welcome everyone.
Thanks for joining us, everyone. I'm Shelley, as Jamie said, and I'm going to get us into the material here. So welcome, enjoy your lunch if you're eating your lunch while you're watching us today, and we'll get started. So our goals for the day today are to have a better understanding of the brain, what dementia is, our 10 warning signs, risk factors for dementia, Alzheimer's disease, how a diagnosis is made, reversible causes of dementia, treatments. We're going to look at vascular, Lewd Body, frontal temporal, and young onset dementia. So we're covering a lot in the 30 minutes. So firstly, we're going to do a quick overview of some of the basic information at a high level on how our brains function and how each part of our brain has a specific role that affect our behaviors, personality, and memory. Our brains are divided into 2 hemispheres and 4 lobes. So we're going to start with our frontal lobes. They are responsible for planning, organizing, memory, and our emotional control center. A person with frontal temporal dementia will be that person you see going outside in a snowstorm without a coat and not realizing why they may need that coat in a snowstorm. They might have no longer have insight that they have dementia. Our parietal lobes are responsible for helping us put things in a logical order and help us recognize people, places, and things. These lobes help us process sensory information from all over our bodies. A person living with these lobes affected may no longer be able to put clothes on in the right order or follow a familiar recipe. They may forget where they are. Our occipital lobes control our vision and depth perception and help us recognize colors. A person with their occipital lobes affected may see a shiny floor as being wet and not walk on it and try and go around it. A narrowing field of vision will occur, and if you approach them from the side or the back, they may be startled. Stares become difficult because of a lack of depth perception. Temporal lobes are responsible for processing visual and auditory memories and for storing them into our short and long-term memory. They help us understand language, both written and verbal. A person with temporal lobe involvement may forget a recent conversation or may not understand what you said to them, having trouble finding words or mixing up one word for another. Our cerebellum and our brainstem control our voluntary and our involuntary movements. As coordinate and balance functions are lost, the person often loses the ability to walk. They become bedridden, which makes them more prone to lung infections. Swallowing difficulties occur, which increases the risk of choking. The cerebellum and brainstem are most often not impaired until the later stages of the disease. Dementia. Dementia is not a diagnosis. It's an umbrella term that describes a wide range of symptoms. It can be reversible or irreversible. And as we can see here, Alzheimer's disease is the most common form of dementia, accounting for about 60 to 80% of all cases. 10 warning signs. We tend to look at these as our ABCs, looking at the abilities, communication, and behaviors, and how these might be changing in someone with a form of dementia. Dementia is not part of the normal aging. When you meet one person with dementia, you've met one person with dementia. It is not something a person can control. Who is affected? As you can see here, the impact of people living with dementia is huge. Currently, about 64% of people diagnosed on PEI are women. These numbers are expected to nearly double by 2031. The focus here is on risk reduction. 60% of dementia diagnosis, the risk is unknown, which means it's sporadic, and 40% are modifiable risk factors. Modifiable risk factors are things we can control. Our choices we make across our lifespan affects our brains and our health in later life. Making the choice to stay physically active, not smoke, protect our heads, and remain socially active will help reduce our risk for developing the disease later in life. Now we're just going to put up a poll question for you.
All right. So I know that was a lot of information in a very short time. So we'll give you a minute here to digest. Again, if you have questions, please put it into the chat pod. Now I'm just going to launch a very quick poll and see how many types of dementia do you think there are between 4 and 10, 20 to 40, 50 to 70, or 70 to 100? Right, I'll just leave a minute or two here. Well, not quite that much, but for everyone to make their answer, final answer. I'm just going to end the poll now. And I'm going to share the results. So very interesting results. What do you think about that, Shelley?
It is interesting. So, and this might be part of our discussion at the end if people have a chance to stay with us. There's actually over 100 different types of dementia. Many of them are mixed forms, but there's over 100. Some of the literature says even over 120, but we're going with over 100 here. So it's interesting to see that we're quite divided in how many types we think there are. So with that being said, we're going to get into the most common type, Alzheimer's disease. So the first and most common type of dementia we're going to look at is Alzheimer's. Physiologically, it's characterized by a buildup of plaques and tangles in our brains. The plaques are formed by a protein called beta amyloid. When the body can no longer remove the buildup of this protein, cells start to die, and that's where the damage in our brains occur. Short and long-term memory are both impaired, and the average duration with this disease is usually about 7 to 10 years. Alzheimer's disease is progressive, which means over time it worsens. It's degenerative, which means as the brain cells break down, more and more abilities are lost. And it's irreversible, which means the damage to the brain cannot be repaired. Often, short-term memory loss is the first symptom the person is aware of their forgetfulness. So they're aware that they're forgetting some of those simple tasks, and that can be one of the hardest things for someone newly diagnosed with this disease or in the process of being diagnosed with this disease goes through. Symptoms are closely linked to the warning signs which we spoke of, categorized in our abilities, behaviors, and communication. Diagnosing dementia needs to be done by a family physician, a doctor, or a geriatric specialist. The family doctor will take and have a solid patient history and rule out possible physical causes, followed by a variety of cognitive tests based on those findings. Sometimes MRIs or CAT scans are ordered. Most often, the cognitive tests are good enough for a diagnosis. Current medications are mostly aimed at symptom reduction. The approved medications in Canada are Aricept, Remenil, Exelon, and Abixa. A new medication called Aduhelm, which is aimed at disease modifying, was approved by the FDA in the States last year and is waiting on the review process from Health Canada, expected at the tail end of this year. There are currently 23 disease-modifying treatments in stage 3 trials, which is the last stage before approval, which is very promising and exciting towards treatments and a cure for this disease. Now we're going to look at vascular dementia, which is often caused due to TIAs or mini strokes. If you experience a stroke, you actually have a 50% chance of developing this type of dementia. Cognitive abilities tend to fluctuate day to day, and you will notice a difference in behaviors. As vascular dementia progresses, people develop behaviors that seem unusual or out of character. Most common include irritability, agitation, and some aggressive behaviors. Often, people with this type of diagnosis have a higher blood pressure, and diagnosis is usually done with a CT scan. This is the second leading cause of dementia because most are a mixed dementia with Alzheimer's-like dementia. Lifestyle changes are the single most effective way to lower your risk factors. For example, changing to a low salt diet to help manage blood pressure, increasing your physical activity, stop smoking or not smoke, and eating a balanced, healthy diet. Lewy body dementia occurs when abnormal protein deposits inside the brain's nerve cells. These deposits are known as Lewy bodies, named after the scientist who discovered them. This form of dementia develops quickly and has a more rapid progression. It occurs more often in males with an almost 2-to-1 ratio and accounts for about 5 to 15% of all cases of dementia. A common symptom is that a person will experience visual hallucinations, which is seeing things that are not there. Often people with this type of dementia report seeing children as their hallucination. A gait imbalance and other Parkinsonian movement features are common. Frontal temporal dementia often occurs at a younger age in people, sometimes as young as 40. In some cases, the brain cells get larger and round silver pick bodies form. This is known as Pick's disease. It affects emotions, behavior, personality, language, and typically has abrupt mood changes. Some common symptoms in frontal temporal dementia are often behavioral and personality changes, impaired judgment, and acting socially inappropriate. A diagnosis of frontal temporal dementia is typically done by a doctor using a variety of tests, including cognitive thinking tests and brain imaging like an MRI. Now we're going to put up another poll question for you.
Okay, once again, since we have a little break here, if you do have any questions, I'm monitoring the chat pod. And here's your question. It's a true or false. Young onset dementia and dementia in older adults are the same. And we'll give you some time to answer that. Okay, that's almost everyone. I'm just going to give about 5 more seconds and then I'll end the poll. All right, the results should be up on screen there.
Well, the poll is pretty accurate this time. So 87% of us feel that it is false, that young onset dementia and dementia in older adults are the same, which is correct. And we will go into the why behind that. So young onset dementia is when symptoms start before the age of 65. Currently, about 365 people, or 13.5% of people living with dementia in PEI, fall into this category. Getting a diagnosis often takes longer due to misconceptions and a lack of awareness around young onset. Young onset has a much different impact due to age. Often people are still working or have small children that they're still trying to take care of. This can lead to a huge financial impact. People are not typically prepared for job loss or to have their mortgage paid off at a young age. Young onset also tends to progress more quickly. So you can see there's a lot of very complicating factors that can happen with a young onset dementia. We covered a lot of information in a short period of time today, looking at some of the most common forms of dementia. I have shared so many different little tips that might help you recognize what type of dementia someone has if they haven't formally had a diagnosis specifying what type under that umbrella term dementia. I hope you've enjoyed the time we've had, and remember that dementia is a very complex disease. And if you can remember one thing, it's that if you've met one person with dementia, you've met one person with dementia, and that everyone is unique, and that we are here to help along, to support with this ever-changing journey. And we have managed to leave some extra minutes at the end for questions with everyone. So that's the end of our formal education piece. And we have a few slides here. We're just going to share about some of our programs and services that we have.
Thank you. And we do have a bit of extra time. If there are any parts of today's presentation that might have gone by a little too quickly or that you'd like us to revisit right now, just pop those into the chat pod, even if it's not a specific question, and we'll spend some time covering that. Just to let you know, the programs and services here at the Alzheimer's Society have gone through a lot of expansion in the last 6 months. We now have family support staff in O'Leary, Summerside, Charlottetown, and Montague. And our caregiver support groups are now in each of those areas as well, starting this month. We are still providing our one-on-one counseling and support and information. We're doing family consultations, both online, and we're back to in-person again. We are providing resources and education as well. Some of our programs include First Link, the Medic Alert Safely Home program, our volunteer companion program, which is like a friendly visiting program for the person living with dementia. You can have a volunteer come to your home for a couple of hours a week to engage and spend time with the person living with dementia. And we also have our Dementia Care training program, and Shelley actually teaches that. It's a certification program in specialized dementia care specifically for healthcare providers. in terms of our upcoming education opportunities, we have next week, how dementia changes sensation and perception. So again, if anybody tell me the part of the brain that's responsible when perception starts to change. We'll be covering that in more detail, what that looks like, what it's like to live with changes in sensation and perception. We'll also be providing sessions on eating well. So what are the things that are healthy for the brain? How can we support brain health across the lifespan or after a diagnosis? And the session following that will be all about physical exercise and dementia. And that's looking at things like what kind of exercise is the best for the brain? What is the intensity that you should be working at? And what is the frequency that you should be exercising? And how does that impact your brain health? If you are a healthcare provider, and you're interested in the full certification program, because again, these sessions are just meant to be really quick little snippets of information, but our DCT program is a very comprehensive, I think 4-day total education program. There are sessions coming up in Summerside, Montague, and Charlottetown, and you can access that information on our website or on social media. Just going to have a look at the chat pod here. So to answer, yes, I'm going to send out the slides to everyone who attended today. So you will have access to this information as a resource. Let's flip the presentation back, since we do have a little bit of time, back to the warning signs, the ABCs. And while Shelley's doing that, there's a question about, if someone was diagnosed with mild cognitive impairment a year ago, but seems to decline quickly, would this be a diagnosis of dementia? So that kind of a question can really only be answered by either a physician, a geriatrician, or a neurologist, someone who would be able to do a follow-up. Typically with someone who's received a diagnosis of MCI, there would be a follow-up a year after the point of diagnosis to do to re-administer cognitive assessments like the MMSE or the MOCA to see if there has been a change over time and what the level of change is over time. So it's basically impossible for me to answer the question without knowing a little bit more. But with MCI, I believe, and pardon me, but I believe the percentage is that 50% of people diagnosed with MCI will go on to develop a type of dementia that is progressive, and 50% will experience that kind of drop in function that resulted in the MCI diagnosis, and then their condition will remain stable. But in terms of actually determining if it's a dementia or not, you would really need to go back and have a follow-up with your clinician, because there are other things, as I'm not sure if you noticed on the slide about the reversible causes of dementia, but there are a lot of things that can impact or impact the brain that look like dementia, but are actually things that can be reversed. For instance, if there's any type of underlying infection, in particular a UTI in seniors, it can cause symptoms that look a lot like dementia. Typically, we would call this a delirium. Also, things like a B12 deficiency, somebody who has underlying pain or depression or anxiety or stress that are untreated can cause confusion. So before you could say that someone with MCI is actually progressing, even if there seems to be a decline, you want to make sure that there's an evaluation done to rule out potentially other things that might be causing those symptoms. And the biggest one, actually, I'm sorry that I neglected to mention, is polypharmacy or medication interactions. So other medications they might be taking that might be causing problems in cognition, and those issues would clear up after the medication interactions are fixed. So I hope that's an okay answer for you. And if you want to give us a call back at any point and chat more in depth, please do so. So we were asked to go back to have a look at these warning signs again. And my understanding from working with geriatricians and neurologists is that when you see a warning sign, in order for it to be suspected dementia, there has to be more than one of these happening. and they have to be impacting day-to-day functioning. So like, let's just look at communication for a second, at problems with language. I, from time to time, have word finding trouble these days, it seems. But I don't have word finding trouble that impacts my ability to move around the world, to do my job. I just might hesitate sometimes in conversations. Now, for me, that's, I'm not saying I have an earlier onset or a younger onset dementia, but for all of us, we have these things. All of us walk into a room at some point in time, and we cannot remember for the life of us why we walked in there or why we opened the fridge and what it is we're looking for. Again, those things are normal, in particular as we age and are over the age of 40. But really, for it to be a suspected dementia, you'd want to see, again, more than one of these and something that's impacting function. So let's just take an example. A difficulty performing familiar tasks. To give you a personal example, if my father ever had trouble changing the oil on a car, I would know that there was something going on, because it's something that he has done thousands of times. Or if mom was suddenly forgetting the recipes, or that she's made her whole life. If someone was getting disoriented in time and place, like they didn't know where they were in downtown Charlottetown, yet they've lived there their whole life, that would be potentially a sign that something is wrong. And then in terms of the mood and behavioral changes and personality changes, when those things are happening first, sometimes it's challenging for families because they aren't sure if it's a mental health issue or if it's actually an early symptom of a cognitive problem with the brain. So again, but it's just to recognize that sometimes those can be happening, the mood and behavioral changes, in particular if the person is struggling because they still realize that they're forgetting, like they're in that state where they understand there's deficits and there might be fear and those kinds of things coming up. Now, I'm just going to go back to the chat and have a quick look. Do you have anything to add on this slide, Shelley?
I agree with everything you're saying. The only thing I wanted to add was that often it's patterns. So sometimes when we're incredibly stressed, we forget some of those simple things. I know there's been a few times where, I'm rushing out of the house and I come back because I'm not sure if I've turned off the stove. So it's not so much, an isolated incident, but a pattern of, mom forgot to turn off the stove 4 times this week and 4 times last week. Let's look at why this might be happening, as opposed to just having the actual behavior noted. Let's look at the why behind it. And often if there's a pattern, that tends to be another indicator.
Absolutely. Would you mind moving forward to just my last slide there? And I'd like to get everyone out on time. Once again, please, if you have a chance to answer the 4 or 5 questions of evaluation that will pop on the screen after, that would be great. A reminder that our biggest annual fundraiser is coming up. We do the IG Wealth Management Walk for Alzheimer's every May. This year, we're excited. We're going to be walking in person again. And not only that, we are going to hold walks in O'Leary, Summerside, Charlottetown, and Montague. We hope you will join us and register as an individual, participate as a team or as a family, and help us as we raise money that funds our programs and services here on the island. You can learn more at walkpei.ca. I want to thank you sincerely for all the team here at ASPEI for joining us today. Hope that you are able to join us for other sessions. And I'll just leave one. I'm going to have a quick look at the chat. If you do have a question, please let us know now. And otherwise, I look forward to seeing some of you next week. And thank you very much, Shelley, for presenting today.
Thank you to everyone.
Thank you.